round, I'm going to turn to the ranking member.
Thank you, Mr. Chairman. First of all, let me describe this as a real problem. And my definition of a real problem is something that doesn't have an easy solution. And first of all, Ms. Bent, my sincere condolences on the passage of your husband. It seems, and again, I've got years of experience buying private health care, watching these exclusions being added to the policies, trying to bring the cost down. I've got all kinds of questions, and I'm trying to figure out how to zero it in. My overall question is, how does this kind of pre-authorization compare with private insurance, and truthfully, what people try to do with normal and Medicare as well? Now, I had in-laws that were being booted out of hospitals way before they were supposed to on Medicare. I don't think it's Medicare Advantage. So can somebody speak to how this compares to private insurance and how it compares to Medicare?
I can start. So I have colleagues that have looked at similar questions in the health insurance marketplaces, but what we've found is that the data are not comparable, so you can't actually figure out how things compare. They have other data that would be nice to have in Medicare Advantage, such as the reason for the denial of payments, but the data for your first question simply is not available.
Let me ask about the services being denied. It seems like an awful lot of what we're talking about here is long-term rehabilitation care. Is that most of the 35 million requests, or what else is being pre-authorized and being denied?
So that data does not tell us the particular services. I think other people on the panel can speak from other data they've looked at or their experience, what they've seen. But that data, one of the big gaps is it doesn't tell us the services.
Oh, yeah, we're always missing information. Ms. Tinker, what can you add?
So when we looked at this data, we took a month in June of 2019, and we really looked very closely at those prior authorization denials. And what we found is they fell into sort of three main buckets. One was post-acute care, which you were just mentioning, transfers from hospitals to either skilled nursing facilities or inpatient rehabilitation facilities. Another bucket that we found was significant were imaging services, specifically things like CAT scans and MRIs. And then the last was injections, generally for issues dealing with pain along the spine. In addition, when we looked at our work and tried to make that comparison against original Medicare, what we found was with those prior authorization denials, 13% of them actually met original Medicare requirements. And one of the Medicare Advantage requirements is that it provide the same level of service that original Medicare does.
So again, I'm trying to get to so why are these services chosen for pre-authorization? I would think with long-term rehabilitative care, that's a big dollar amount, correct, in Medicare Advantage? The other two buckets you mentioned don't necessarily fit in that category. Are some of these services generally abused or used when they're not needed?
We have other evidence that shows that there are issues around fraud in the injection space. And so that may be one reason that prior authorization is there. That's not something we looked at explicitly in that particular study. But yes, it's not as expensive as issues around post-acute care.
So are you seeing similar types of problems in primary Medicare?
We don't have any work that looks specifically at primary Medicare on those particular issues, and prior authorization is not used as prevalently.
Right, but denial of service or being booted out of a hospital early, I mean, those are probably issues in Medicare as well, correct?
Specifically in the report that we did in the study from April of 2022, what we did though is looked at Medicare Advantage prior authorization denials and how they compared to the rules in original Medicare. And so the findings that 13% of the time original Medicare would have paid raised significant concerns.
Now was that 13% on appeals, or is that 13% across the board in terms of the denials?
That was across the board in terms of denials.
Okay. Well, Ms. Graber, I think you were putting your finger on why this is occurring. People trying to control costs. Do you have any idea in terms of what the total dollar amount is that's at stake? I know you mentioned one figure. If you can kind of restate that.
Sure. If you take sort of one of the examples that Megan just illustrated in post-acute care. We don't know the full amount on the Medicare Advantage side, but on the fee-for-service side, that's about $60 billion in annual spending. So if it's 50-50, kind of figure that's the same equivalent on the Medicare Advantage side. So you're probably looking at a total of roughly $120 billion in annual spending just in post-acute care.
The chairman pointed out how much money Medicare Advantage is making per patient. If you wiped out those profits, kind of what would happen to Medicare Advantage, where would they try and make things up?
They might try to make it up on the fee-for-service side.
Describe that a little bit more.
So on the fee-for-service side, and in my testimony, I referenced some of the margins that providers enjoy from the fee-for-service rates. So there's certainly a discrepancy there as well. And I think the Medicare Advantage plans are paying attention to that on the fee-for-service side. And they're using tools like prior authorization to get at making changes and to bring some of those margins down. That's their ability to do that on the Medicare Advantage side. Where on the fee-for-service side, we can't really get at those costs and inefficiencies in the Medicare program unless Congress authorizes it.
Are they also using the savings of the pre-authorization and then denial, either justified denial or unjustified? They using that to fund the other benefits like dental and vision, that type of thing?
Yeah, they're reinvesting the money that they get from the Medicare program in a variety of different things. So supplemental benefits such as vision, dental, and hearing, and a whole host of other things that are offered to beneficiary on the Medicare Advantage side that they're not able to get on the fee-for-service side.
So if the solution to this problem would be, we're not going to let Medicare Advantage plans do pre-authorizations, we're not going to allow them to deny coverage based on pre-authorizations, what would end up happening is probably one of two things. Either the cost of the taxpayer could go up pretty dramatically, or Medicare Advantage plans would have to pay her back in terms of what they cover. I mean, I would think those are the two most likely scenarios, correct?
Yeah, I would say that both of those things would happen.
Okay. I have no further questions. Thank you.
We'll turn to Senator Marshall. I'm going